I hope I am audible.
Yes,
Yes,
you're
you are.
audible.
Yeah. So, thanks to the organizers for having me at the MI Symposium, which is a celebration of our togetherness, all Aster teams, all across the borders, across the seas, all brought together, thanks to the vision of our Honorable Chairman. And congratulations to Dr. Harsha and his entire team for making the vision a reality. So, I'm Dr. Mohammad Faiz. I'm a very, very small doctor because my patients are very, very small babies, that is the fetus. So, this is our patient, the fetus, and how we took care of the fetus during the COVID pandemic. That is the topic today, pandemic and fetal medicine. I'll be sharing some of our practical experiences and then we'll go to some of the evidence-based practices. So what is COVID-19? It's a viral infection caused by SARS-CoV-2. It is spread by droplet and contact, and it can cause mild fever, cough, shortness of breath to severe ARDS and even death. So it is a highly contagious and deadly disease. So we have to safeguard ourselves and our patients from it. So fetal medicine, what we are doing here or what different we are doing here in our department. So we are giving a passionate work with advanced and expert level scans, and we have too much compassion for our patient, that is the baby and the family of the baby. We not only do the scans and send the patient off, but we counsel the parents, explaining them the condition of the baby and giving them the options available to deal with the situation of the baby if there is any complexity. And we get into contact with the parents and become a part of their family in taking care of the baby. We get in contact with other team members, other doctors who are involved in the care of the baby, maybe the high risk obstetrician, maybe the neonatologist, it may be a pediatric cardiologist, pediatric neurologist. We get into discussion with the entire team to give best possible care to the baby. And of course, when there is a complex malformation in the baby or any complexity, the treatment will also be very expensive. So we do have contacts with some of the charities. For example, I am here in UAE. So His Highness Sheikh Mohammed bin Rashid Al Maktoum has his own charity funds. And also His Highness Sheikh Khalifa has a big foundation here and they extensively help the patients. So we just give their numbers to our patients to help them across financially as well. So this is not only clinically advanced and expert level care, but also a more of humanitarian care to our patients. So some of our practical experiences I would like to share before going directly into some clinical cases, some management challenges which we faced. For example, there was at the beginning of COVID, there was staff shortage and equipment shortage. And in interest of the patient, and we are scanning the heart of the baby, the four-chamber view, then we are seeing a single vessel coming out of the heart instead of the pulmonary artery and the aorta. We are seeing only a single trunk coming out from the heart. And as it comes out, it gives a lateral branch, another lateral branch, it goes more cranially and gives even the head and neck branches. So what is this condition where single vessel comes and divides into pulmonary arteries and then continues as the aorta? It is common arterial trunk. Not only common arterial trunk, this baby also had this problem. As you can see, there is club foot arterial trunk. We offered genetic testing for the baby, amnio and array was done, and it was found to be DeGeorge syndrome. So the mother was late for the scan because she herself thought that COVID is going on, so no need to go for any scan, no need for any antenatal consultation, nothing. And she was very late, and termination of pregnancy was not possible at that time. And she continued till term. And continuing pregnancy till term means the bonding with the baby was also continuing. The baby was born, lived for a few days, and then died in the neonatal period, which led the mother also in severe mental depression. So this is how lack of knowledge among the patients affects them badly. This is another case, the second case, where the mother was well educated about the visits, came in time, and we diagnosed a complex cardiac malformation. You can see that in the four-chamber view, we are not seeing one of the ventricles. One of the ventricles is hypoplastic. This is the spine of the baby. And yeah, this is the spine of the baby. This is the aorta. The left-sided ventricle is absent. There is only one ventricle on the right side. And you can see in the right-sided ventricle, there is no moderator band. So this is not morphological right ventricle. This is a right-sided morphological left ventricle. That is, there is ventricular inversion. And further, we can see there is one artery coming out here from this morphological left ventricle. And this artery gives lateral branches. So this is pulmonary artery. So pulmonary artery arising from left ventricle instead of right. So first there is atrioventricular discordance, and then there is ventriculo-arterial discordance, double discordance. So this is a case of transposition of great arteries. And TGA we know is it can be DTGA or LTGA. So apart from these two conditions, there is one more condition which is very rare, which it is known as congenitally corrected transposition with D malposition. Congenitally corrected transposition usually is L malposition, but very rarely the congenitally corrected transposition can be D malposition. D malposition means the aorta will be coming anterior and to the right of pulmonary artery, as you can see here. It is anterior and to the right of pulmonary artery. So this was a case which was seen later by a MFM specialist, by a pediatric cardiologist. But most of the findings related to great arteries were missed in their scans. And even this patient has a terminal coarctation of aorta, which makes the case a drug-dependent circulation, where the baby has to be maintained on prostaglandins in case to make the baby survive after birth. But even the coarctation was missed in the scans. So this made us think why, after all the malformations of fetal great arteries, which are most deadly malformations, are also the most commonly missed malformations. And the people who were doing the scans were not like any inexperienced people or untalented people. They were experts. They were pediatric cardiologists. They were MFM specialists. They were missing such cases. So the reason what we found out is that there is no technique which is described in the literature on how to scan the fetal great arteries completely. Either we can scan the outflow tracts or the three vessel view or the three vessel tracheal view, segmental approach. There was no technique described to completely trace the fetal great arteries. So this led us to think and come with a research where we described a new technique of completely tracing the fetal great arteries, right from their origin in the ventricles to their termination in the descending aorta. So this was one of the research we conducted. Then we went on to another research, which was on TGA, a definitive sign for ruling out TGA, because TGA is the most oftenly missed diagnosis. So we came with a definitive sign to rule out TGA as well. Now coming back to this baby, you can see the complex cardiac malformation. We told it is a duct dependent circulation. After the baby was born, the baby was kept on prostaglandins. And even then, the baby could not be maintained for long on prostaglandins. His condition was deteriorating. So on day one itself, open heart surgery was performed, and he was treated on the univentricular pathway. That is, Norwood procedure was performed with modified BT shunt. And then at 6 months, again, the baby underwent a second surgery, that is Glenn procedure. And now you can see the baby is doing very well. He's playing around, he's charming, smiling. Looking at the baby, you cannot tell he had such a complex cardiac malformation and which was treated. Of course, he's doing well now. So These two examples show us how important it is to educate our patients and how important it is to do research and educate our doctor community about new techniques in doing the things well. This is our patient education leaflet which we prepared here and circulated among the patients, the pregnant mothers, COVID-19 and pregnancy. This is patient information leaflet to make them know when to visit, when to avoid, which visits they can avoid, and which are the compulsory visits they have to make, and other questions related to COVID-19 and pregnancy. Now, regarding research, as I told you, we described two new techniques in fetal echo. And also we did an administrative research. This is an interesting one. The administrative research was conducted on AMI itself, that is Aster Medical Imaging. How was the performance in 1 year of AMI? We audited the data all across the countries, and we analyzed the data and made an evidence-based presentation of the AMI performance. So coming to the scientific presentations, the scientific research, if I say that I have found new technique to scan the fetal great arteries, then who will believe it? No one will believe it because I am nobody. So I have to present these techniques, I have to submit them to a scientific committee of an international standing, international authority in that particular field that has to accept my techniques. Only then it will be something authentic. So by God's grace, both the techniques were accepted. And they gave me an opportunity to present them at the ISOAG World Congress 2021. And now they are already published in international indexed journals. You can see in various journals they have been published with the author's name and the name of Aster DM Healthcare. Now coming to the administrative research, the title was Improvement in Healthcare Quality, Safety and Operational Efficiency through Digital Transformation of Medical Imaging Department in COVID-19 pandemic and future plans to make the gain sustainable. So what we did here, we collected the data across all the countries, audited it and analyzed the data and made an evidence-based presentation of our work at the ADHQS World Summit. This is a world-class summit. And you can see among the beautiful speakers here from USA and UK, this ugly one is me from UAE, who beautifully represented AMI at the World Summit and improved AMI's brand visibility and trust among public as well as health regulators. So we do have some prospective research plans also, and the topic we are thinking about is ultrasound-based radiomics in fetal medicine. Now, this topic particularly I have selected because my own personal interest in fetal medicine, our honorable chairman's vision of AI research in medical imaging, and also the government of UAE is particularly interested in AI and genetics. So radiomics, we are going to combine radiology and genetics, that is radiomics. So in this way, UAE government, it has all the financial capabilities, it has all the resources, and at Aster, we have the staff talent, we have the technology. So there is a very good chance of getting into a public-private partnership. So to sum up all the practical experiences, the things which helped us to face the COVID challenge and come out stronger from it were cross-leveraging, teamwork, digital transformation, consolidation, education, and research. And all these things were given to us by Aster Medical Imaging. This is what the impact AMI had, which helped us not only to survive the pandemic, but to come out better and stronger from it. Now, coming to evidence-based practices, these are nothing but the guidelines given by international societies, how we should prepare the fetal medicine department, how we should sanitize it, clean it, make the arrangements, schedule the appointments. This is not much different from general radiology. So I think this slide is the only one which is something different, because in this they have given which scans can be avoided compared to pre-COVID time during the pandemic, which can be avoided. For example, the early 6 to 10 weeks dating scan can be combined with the 11 to 13 weeks anti-scan, and dating can be done there. And the 18 to 20 weeks anomaly scan should be given priority. Those patients having anomaly scans should be given priority over other cases. And we are discouraging walk-in patients and taking walk-in only in case there is an emergency like ectopic, APH, etc. And growth scans and all we are avoiding, the Dopplers we are avoiding except one scan at 36 weeks. But this doesn't apply to the decision-making scans like FGR and TIH, where the decision of when to deliver the baby, where to deliver the baby, how to deliver the baby, all this depends on your growth scan and on your Doppler. So this cannot be avoided. This has to be followed with a proper protocol such as Barcelona protocol. It has to be applied. Now, patient scheduling. There are international guidelines on how to schedule patients, but as I already told you, we custom made these guidelines for our local setup and transformed everything into a more digitalized service, like patient appointments online, on call, or through apps. When the patient is coming in, the front office is informing us all the information about the patient digitally, and we are prepared for the patient by the time she reaches the room. And once she reaches the room, we do the scan and we send off the patient, and the reports will also be sent digitally. So all these new technologies, new techniques of maintaining the department were possible because of our staff cooperation. We have rewards and recognitions for our staff as well. Now, given by the vendors to clean the probes. And we have to keep all the PPE and other materials in advance in the stock. And staff shifts and education, the older patients, the cardiac patients, the pulmonary disorder patients, they have to be given some time away from the patient contact. They have to be kept away as much as possible from getting into direct contact with patient. The staff roster should be shorter and work in rotation so that all of them do not get infected at the same time. Staff must be trained in using PPE, disposing PPE, hand washing, and all scheduling should be done. Patients should be taken by appointment and discourage walk-ins. And yeah, take all the patient histories and consents and maintain social distancing. Train the staff on donning and doffing PPE. In summary, the resources should be prioritized and optimized with emphasis on avoiding exposure and containing the spread, and stopping the spread from patients to healthcare professionals and from the staff to the patients. And very essential thing is to plan the number of visits of the mother, and it is wise to consider everyone as an asymptomatic carrier and take all our precautions. These are all my references. Thank you very much for patient hearing. Thank you again.